Hello guys, how are you all? Today we will discuss some Gynae recalls question from AMC part 1. Let's start. 34-year-old multigravida whose fetus is known to be in breech position. Present to the hospital for vaginal delivery. After spontaneous rupture of the membrane, you notice bradycardia and variable deceleration on fetal heart rate monitoring. Vaginal examination confirms cord prolapse, however, the cord is still pulsating. Which one of the following would be the most appropriate next step in the management? A. Push the presenting part as far as possible and keep it back with digital pressure. B. Continue vaginal delivery. C. Give oxytocin to enhance contraction. D. Prophylactic antibiotics. E. Fetal scalp blood sampling. So let's rule out some answer here. So if we will go, let's see what is explained here. So this is the actually the cord prolapse. This is actually the cord prolapse, and continue the vaginal delivery will be the wrong answer here, because cord prolapse is emergency condition and we need to expedite delivery by emergency cesarean section. We cannot continue normal vaginal delivery here, so that's how it is the wrong option here. Give oxytocin to enhance contraction. We cannot enhance contraction. We want to be less cord pressure, so the cord will be can easily flow the blood. So we will try to apply the less pressure or on the cord. So we will not give the oxytocin to enhance contraction. We will give some relaxant to cord to be with a good flow. So this is the wrong answer here. Give oxytocin to enhance contraction. Third option, D, prophylactic antibiotic, is the also the wrong answer here. No use for prophylactic antibiotic in the cord prolapse scenario. So this is the wrong, and fetal scalp blood sampling is also the wrong answer here, because it will take some time and the cord prolapse is an emergency condition and we have to expedite delivery by emergency cesarean section. Till that, we will try to maintain certain position to avoid the pressure on the cord, so cord can easily flow the blood and it will not collapse. So we will try Mcqs position. So this A seems correct answer here. Push the presenting part away. Push the cord up as far as possible and keep it back with digital pressure to maintain some flow on the cord, so the head will not compress the cord. We will try to push the presenting part away so the head will not compress the cord. So that's the reason we will try to push the presenting part away and push the cord as far as possible. We will try the cord should have a good flow and keep it back with the digital pressure. So this is correct answer here. Let's see the explanation as well. Correct answer is A. Cord prolapse present with the abnormalities in the fetal heart rate pattern, bradycardia and variable deceleration. If this changes begin after the rupture of the membrane. Yes, this is very important thing. Usually cord prolapse happen when the rupture of the membrane done either spontaneously or either amniotomy hydrogenically. So this has happened always after the rupture of the membrane. Cord prolapse should be strongly suspected if it happen some bradycardia or variable deceleration after the rupture of the membrane, then most likely the diagnosis will be the cord prolapse. So sometimes the diagnosis can also questions coming for the diagnosis. So if the scenario happens like bradycardia and variable deceleration just after the rupture of the membrane, most likely diagnosis will be the cord prolapse. Umbilical cord prolapse is abnormal position of the cord in front of the fetal presenting part, resulting in a cord compression. That's why we want to maintain certain position, because when the cord prolapse happen, the presenting part gives a cord compression. So we will try to move the presenting part as far as possible to avoid the cord compression. So that's the reason that fetal heart rate abnormalities are coming, like in the form of bradycardia and variable deceleration when the cord compression happen during the cord prolapse. So its result, the cord compression result in fetal hypoxemia, and that's the reason for abnormal fetal heart rate pattern, and it is detected on the CTG. So once the diagnosis of the count on the pelvic examination and the cord is still pulsating, that's mean that the fetus is still alive, and the presenting part should be pushed away with the examiner's finger, followed by pushing the cord as possible and maintaining the digital pressure. The mother should be placed in a knee chest position. So this position will avoid the cord compression and will maintain the normal blood flow. As so this position, we will from this position we will achieve the less pressure on the cord, which maintain the flow of the cord. So with the examiner's hand in place, we will maintain this position and rush to the operating room for emergency cesarean section. This is again the important point here, because for the cord prolapse, always emergency cesarean section is the best answer for the appropriate management. With the being unstable and severely hypoxemic reflected by a variable deceleration on heart rate monitoring, there is no place for vaginal delivery and emergency cesarean section should be performed. So this is the correct answer here is push the presenting part away, push the cord up as far as possible and keep it back with digital pressure. So they are asking here the appropriate next step. So this will be the next step. In case if they will ask you the most appropriate step, only the appropriate, then in the option if somewhere emergency cesarean section there, just mark that option, because cord prolapse, in the cord prolapse the most appropriate management is cesarean section.